was mentioned before that infants might benefit from probiotics by having the mother take it during pregnancy. Is there any idea of when the optimum time for her to be taking these probiotics would benefit the infant?
No, we don't know that, because the studies so far, as I quoted, have been limited to the last 4 weeks of pregnancy. And the reason haven't really been because I don't think any of us, having done these studies, were aware of the fact that the gestational period may be more important immunological than we thought only a few years ago. So the reason for picking 4 weeks was actually to make sure that the mother was properly colonized, and assuming that under normal vaginal birth, the baby would be colonized with the same strain. So it was another reason for doing it than thinking of maternal immunity. Had I done this study again today, I would probably have looked into precisely what you're asking. But to my knowledge, nobody has done it yet.
Well, I'd first like to thank the speakers for the talks. I enjoyed it. I have numerous questions. One goes along with what was just asked in terms of when we have parents who have already had a child with atopic disease and or potentially a premature infant. Clearly, all probiotics are not created equally. Which probiotic should we be recommending for those specific disorders, i.e. atopic disease, allergic, and or potential preemies and neck? When do you do that? And likewise, is there a benefit to, once the infant is born, to, in addition to administering probiotics, to simultaneously be administering prebiotics?
Well, the study is on, when you're asking specifically for allergy or eczema and prevention, then it's Lactobacillus GG, which I'm sure is available in the US as well, and then it's Lactobacillus reuteri. And the other part was prebiotics. Yeah, I think again that you maybe get different answers from the panel, because theoretically prebiotics are really interesting because they would sort of alter the entire microbiota. But the problem is that they haven't done the studies. There is only, to my knowledge, one study that suggests a modest effect on prevention. We could discuss flaws in that study and the quality of it. And so again, they haven't done the studies yet. The documentation so far has been largely limited to probiotics.
I don't think in the States it's a standard of care to use probiotics on premature infants, especially because the premature infants that are at risk is like less than 1 kilo, so babies less than 28 weeks, and the safety of the probiotics in this population of very small babies, it hasn't been proved with all the caveats that Dr. Saavedra mentioned. In other countries, for example, in Colombia, what was done the first study that proved it was a randomized control trial, but it was a retrospective historical control, and they were able to decrease the incidence of necrotizing enterocolitis for a very high proportion to a lower proportion. It's the standard of care. What probiotics they use? That's a problem, because there is even the 2 studies that Dr. Lin did in Taiwan, there is a difference. They both had Lactobacillus acidophilus, but the bifidobacteria was different in the first study and in the second study. And that product is not anymore available. So there is no good recommendation for what probiotics to use for prevention of necrotizing enterocolitis.
In a children's hospital attached with a women's hospital, and we have the mothers come in who are in premature labor, should we start giving the mothers probiotics before they deliver?
At this point, that's a good idea, but nobody has proved that that will help. The problem with the premature infants is that you don't know when the prematurity is going to come. So if you try to prevent something in premature infants through the mom, you have to start very early because you don't know when the mom is going to deliver, 26, 27, 28 weeks. But it's a good idea, but so far there is no study proving or disproving that.
And just to add, so that's allergy and necrotizing enterocolitis. And look at diarrhea. The larger number of trials which have shown efficacy have been the same with Lactobacillus rhamnosus GG, with Bifidobacterium lactis, BB12, and with L. reuteri. Those three are probably the ones that have the best data from the point of view of management of acute diarrhea, mostly rotavirus diarrhea. And I did just want to make one last comment with regards to prebiotics. I think prebiotics have long ways to go. We're probably about 15 years behind with pre than where we were with pro in 1990, but I do think that there's going to be a lot of information coming. However, there is a very big difference conceptually as to how they might help compared to how probiotics help. Probiotics means putting bacteria orally in the proximal gut, where today we have hardly any. Prebiotics are carbohydrates. If anything, they're going to modulate bacteria in the distal gut. And the way the distal gut diversity works versus how stimulating the proximal gut today work are completely different. So I can't even expect that the results are going to be similar or the same. Increasing certain species of bacteria in the colon, where you already have 10 to the 12th, is very different than increasing, going from almost 0 to 10 to the 6th or 10 to the 8th in the jejunum, where we today have very little. So the immune modulatory effects on probiotics, this is oral live bacteria, is one thing. Giving soluble fiber with, which is prebiotics, which have other effects like increasing short-chain fatty acids, lowering pH. It may help constipation, for example, even in premature infants. But that's going to be a whole different set of mechanisms by which prebiotics may help. And ergo, we would expect the clinical outcomes also to probably be different. But the work needs to be done.
I had a statement for Dr. Savino. About 6 years ago, a pediatric surgeon in California spoke at a lecture, and he traveled to South Africa. He worked in South Africa 6 months, worked in California 6 months, and he came up with this concept, his theory, that he swore that the children in South Africa had different pain tolerances, and it was due to the gut flora. And I thought that was the most outlandish thing. And but he brought up Burkitt's lymphoma and the whole, and so he, and here it sounds like, this is one of the first times I've heard this, but it'll be interesting to see because he swears by this, and he saw the difference in their pain tolerance, and he feels that these children were just exposed to everything and had different pain tolerance.